Cardiology. The questions on cardiology, you will have some questions about acute coronary syndrome and stable angina. One of the examples, there is this old guy who came with a chest pain. This chest pain is new or unstable, or patient has increasing chest pain on rest. EKG, no STT changes, but troponin is positive. So you are thinking about ACS. They may ask you about what's the next step, what you're going to do for him. You need to admit him, you need to put him on heparin infusion, anti-anginal medication, make sure he's on high dose statin. But they may need you to understand that you need to risk stratify this patient within 24 hours to 48 hours and to understand where this patient has to go. Is he going home with anti-anginal medication, or is he going to a stress test or a cardiac cath? If it's stable angina and the patient is not experiencing any recent changes in his chest pain, and this is stable and EKG negative, troponin negative, anti-anginal medication can be followed as an outpatient. But if the patient is labeled as ACS, then you have to risk stratify him with a stress test if he's eligible for a stress test and he can do stress test. Patient that is high risk and high probability and or there is a contraindication to do the stress test, then your answer will be to go for a cardiac cath and find out where's the lesion. If the troponin keep trending up, if there is a significant STT changes, then he needs to go for the cardiac cath within 48 hours. Of course, you need to understand the use of beta blocker within the first 24 hours that decrease the risk of infarct area, and you need to understand the contraindication for beta blocker as bradycardia, acute decompensation, heart failure. The use and the rule for TPA thrombolytics, especially if the patient's away or there is no available center for primary PCI within 3 hours. You need to understand the contraindication for TPA and thrombolytics. Especially one of the cases was there where the patient has a recent stroke within 3 months. Then those are one of the contraindication. The use of anticoagulant as warfarin if the patient's INR is 1 to 2 or less than 2, and what you're going to do with the thrombolytics or giving thrombolytics. Stress test. There is always a 1 or 2 question about stress test. What type of stress test for your patient? Is it going to be an exercise stress test, EKG, and the patient go and run on the treadmill and you find out if any changes on his EKG. So to understand what type of stress test, you need to answer 2 questions. One of those questions is, can the patient walk or can't? And what's his baseline EKG? Is there a baseline changes, or he looks something? If he goes on the treadmill, you're gonna catch something. So if the patient can't walk, of course you're not gonna put him on treadmill. If he has a baseline EKG with a left bundle branch block, this is not gonna help you with the diagnose him if he goes to the treadmill. So those things, then you need to go for the next step, which is pharmacological test. We have the pharmacological perfusion test, which is Lexa scan or adenosine or nuclear scan for the heart. And what you're going to see is, you're going to see without giving the patient any kind of stimulants or any kind of like the butamine or pressors, or it's just going to show you the area of perfusion or perfusion defect. Those patients are good patients to use if the patient has a baseline abnormal EKG or the patient can't walk. But you need to understand there is a risk of adenosine allergy or severe reaction or severe bronchospasm, so those patients are excluded. Then what's the other option? The other options will be dobutamine echo. And the dobutamine echo will give you an answer by looking to the wall motion. So if there is a wall motion abnormalities, you're going to catch, or there is an increased risk of this patient to have an ischemic heart disease. So the exclusion for the dobutamine test, if the patient already baseline has a wall motion abnormalities, like a left bundle branch block, or he has a pacemaker that's going to give you septal motion defect. So at this time, this is not the right option. So when to say this exercise test is positive or high likely positive, or this exercise test give me a poor outcome. If it's a treadmill or exercise test and the patient has less than 5 METs, that means that he gonna perform poorly on the test. If the exercise test induce chest pain, again, this is a poor outcome. If the patient is unable to achieve 80% of predicted maximum heart rate, which is 222 minus his age, if there's a fall in the systolic blood pressure below average during the exercise, especially in early of the exercise. So if the early exercise he just started and his blood pressure just dropped, then this is a poor outcome. If there is any EKG changes that tell us there is an ischemia, just like ST elevation, that's very serious. ST depression more than 2 millimeters, an early onset of downward slope ST depression. If there is a ventricular couplets or tachycardia in multiple leads, and also those couplets of VTACs or multiple tachycardias, especially during the recovery time, that's a poor outcome and tells you this is a positive stress test. You will have a couple of questions about management. What you're gonna do if the patient has a coronary artery disease? He already did the cardiac cath and there is a lesion there. It depends. If the patient has only one lesion and that's symptomatic, and usually the cardiologist will decide if it's above 70% or that was a stress test positive at that area and he was already maximizing on anti-anginal medication, then the best option is to put a stent there. But what if the patient has a triple vessel or left main heart failure? Then you need to understand the indication for coronary artery bypass grafting, which is the surgery, open heart surgery. And it's been studied that patients, and still the rule and the guidelines, if the patient has a triple vessel disease or left main, especially with reduced ejection fraction, it's the best option for him is CABG, and that will decrease his mortality and decrease the hospitalization and recurrent hospitalization. Especially also if the patient is diabetic, or if the patient has, as we said, reduced left ventricular ejection fraction. You will have also some question about a patient who came to the hospital with angina or unstable angina. You're gonna start him on antiplatelet therapy or dual antiplatelet therapy, but the patient also has history of GI bleed. So if you're gonna start dual antiplatelet therapy and patient is suspected to have high risk or be known to have history of GI bleed, then it's the time to add PPI. And you may have that question when they're gonna ask you what type of PPI. Or maybe they have two options of PPI, omeprazole and esomeprazole or pantoprazole. It's the safest to use pantoprazole with Plavix because of the interaction between the Plavix and the other PPIs for the cytochromes. So it's better to avoid that. You may have a patient with a coronary artery disease. He is in his 70s, late 80s, early dementia or memory problems, and he's on maximized on anti-anginal medication, but his geriatrician or primary care decided to give him donepezil for the memory problem, and he came back with maybe a bradycardia, hypertension, altered mental status. You need to understand that's donepezil side effect, and you need to stop that medication. And always with elderly, as a standard, try to avoid unnecessary medication. They may have a question about post-open heart surgery chest pain, and you need to understand that there is a risk and chance for autoimmune pericarditis. Yet, coronary artery disease is still there, and the possibility is there, but is this an autoimmune or Dressler syndrome or early Dressler syndrome, and how to manage that? The use of NSAIDs, the use of colchicine, and the use of steroid if indicated of not responding to NSAIDs and colchicine. Aspirin, high dose aspirin. So you need to understand and know when to use which is which. they may have a case about a patient that is recently discharged with dual antiplatelet or because of ACS or unstable angina, and he came back with a chest pain. So if it's within 1 month, you need to understand what's happening if this is related to stent thrombosis. Management of heart failure. Heart failure management is one of very common on the test, and it's good to know the patient ejection fraction and to know if he's a reduced ejection fraction or preserved ejection fraction heart failure. Know all of those GDMT medications and when to use them and what's the indication for them. What's the indication for ICD? ICD is a defibrillator that's used when the ejection fraction is below 35 and the patient has symptoms of class 2 or 3 heart failure, New York heart failure classification. But if the patient is asymptomatic and ejection fraction below 30%, still he's indicated for ICD. If the patient has a history of sustained VTAC, underlying already cardiomyopathy, prior VFib, unstable VTAC, then also again there is an indication for ICD. If the patient already class 4 symptomatic, means he has symptoms of heart failure even at rest without any exertion that's advanced, there is no indication for ICD unless the patient is candidate for heart transplant or LVAD placement. You mean you're gonna put the LVAD for this patient for what? It's bridging for a surgery, bridging for the heart transplant. But if the patient is not candidate for the transplant, then you don't need to put the ICD or the LVAD. After ICD is the use of CRTD. Think about it as kind of upgrading to the ICD. It has the function of the ICD, synchronizing the right ventricle with the left ventricle for contraction. We use this device when the patient EKG looks wide QRS more than 150 seconds, and especially with a left bundle branch block. It's been studied and proven to decrease mortality, improve outcome, quality of life, and even avoid or prevent remodeling of the heart. Indication for acute PCI, yes, also the indication for post myocardial infarction. So again, there is no indication for post MI ICD immediately during the time of infarction, because that the patient may has a heart failure that's due to hypernating or stunned myocard, and at this time you don't need to put an ICD. You have to wait for the patients around 3 months post PCI revascularization, or around 40 days after MI without revascularization. Also, if a patient came with non-STEMI, troponin positive, he has to go for cardiac cath if he is high risk patient, means high risk for significant stenosis and large infarction, means his troponin keep trending up, there is new ST changes, ST depression, recurrent angina despite maximizing therapy and heparin infusion, hemodynamic unstables, VTAC, unstable VFib or unstable VTAC, or previous PCI, as we said, 6 months or less. That means very high risk for stent stenosis and thrombosis, history of a cabbage, high risk patient for coronary artery disease, and if ejection fraction already below 40 or TEMI risk score more than 2 or heart risk score is high more than 2, then you think this patient is very likely this MI or this troponin is from coronary artery disease. Again, heart failure management, you may have this African-American patient, black patient that came with signs and symptoms of heart failure, and all medication were optimized. You give him beta blockers, you give him ACE or ARBs, and patient still have symptoms of heart failure. It's the time to add hydralazine nitrate. It's the only one was missing there, and it's been studied and decreases mortality in those populations. Maybe you have an African-American patient that New York Heart classification 3 or 4. He's already maximized in nitro and hydralazine, and the question was about Are you going to optimize him more? Is there something else you can add? Aldactone, ICD? If there is no isosorbide dinitrate hydralazine, then it's the time to go and give it. Heart failure with reduced ejection fractions, the optimization has to be including ACE inhibitor or ARBs, and if he's already on ACE or ARBs, or even you can start ARNI immediately and Tresto. You don't have to wait to give the patient ACE inhibitor and give him. So ARNI will be on the test there to give it to the patient as much as the blood pressure is tolerated. If he's already taking the beta blocker, aldosterone, those medication decrease and reduce mortality on patient with reduced ejection fraction. Patient already on ACE, ARNI, beta blocker, ejection fraction below 40. He has a diuretics for volume balance. Is on aldosterone if ejection fraction below 35, New York classification 2 or 4. SGLT2 inhibitor for patient with symptomatic stage 2 to stage 4. Hydralazine nitrate as an alternative even for ACE inhibitor. Digoxin only for persistent symptoms despite optimization with will decrease the hospitalization. Heart failure with preserved ejection fraction means normal left ventricular systolic function. Those with concentric hypertrophy, hypertension, severe LVH, obesity, diabetes mellitus, even coronary artery disease, and other risk factors like obstructive sleep apnea or Afib. You need to understand who's those patients and who's on risk, because treatment start by targeting those risk factors and underlying disease. Patient with preserved ejection fraction treatment needs to optimize volume status. If they need diuretics, you give diuretics only as needed. Aldosterone or mineralocorticoids antagonist help. SGLT2 inhibitor helps. Diuretics for volume, antihypertension medication to control the blood pressure medication and to reduce the afterload. Treat the triggers or treat the risk factors, as we mentioned, obstructive sleep apnea, Afib, coronary disease, diabetes, obesity, hypertension, concentric hypertrophy. Cardiac rehab help. You may have a question about Takotsubo, and the question may be either for diagnosis, treatment, or management, or the role of cardiac cath, and it may have a question about when this patient gonna recover. Usually they recover from 2 to 4 months, 8 to 12 weeks. Again, management of heart failure and the role of ivabradine. Ivabradine is indicated if you already optimize your patient, especially with the beta blockers, and maximize the beta blocker, but the patient still have low ejection fraction, less than 35%, sinus rhythm, and his heart rate above 70. So this is good time to start him on ivabradine to control his heart rate. The patient with core pulmonary, right side heart failure, they have a raised GVD, lower limb edema, maybe even lymphedema bilaterally. They have severe tricuspid regurg, increased RV pressure, increased S2, loud S2. AKG may show right side straining, right ventricular hypertrophy, S1, Q2 to Q wave in lead 3, straining right axis, signs of pulmonary hypertension. Echo can help, of course, for the diagnosis. And if you look to the echo, you may see something called paradoxical bulge of the right ventricle to the left ventricle during systole. So once that contraction happens because of the right side overload and congested right side, we will push the septum to left side during contraction. The normal way to see the opposite, the septum will bulge to the right ventricle during systole, not to the left ventricle. HOCM or hypertrophic obstructive cardiomyopathy. If you diagnose this patient with this diagnosis, you need to do family counseling and genetic counseling for the whole family. Patient known or already suspected to have HOCM should undergoes with a familial evaluation for inheritance and receive genetic counseling. For clinical diagnosis, we use transthoracic echo. On EKG, you need to look to the EKG, and that will help you to save time during the test, you're going to see signs of severe LVH with negative deep S wave in lead recorded chest V2-3 and high R wave in V5-6, 4-5-6. You may see deep symmetrical T wave inversion in V3 to V6. That's where is the severe LVH septum, anteroseptal, or mainly in the septum. So V3, V4, 5, 6, deep symmetrical T wave. Infralateral dagger shape of the T is called like a dagger shape. So you can just Google it and look to that EKG. You may see a narrow, deep Q wave you may see the deep symmetrical T wave with deep dagger shaped Q wave in lead V3, 4, 5, 6. And you may say Q wave also in the inferior leads, which is lead 1 AVL and lead 3 AVF. May gonna see some non-specific ST changes which is related to the LVH. Treatment, you may not have a question about treatment, but it always included beta blockers, calcium channel blockers as an alternative, and the use of ACE inhibitor if there is signs of heart failure or ejection fraction below 50. If the patient already has an Afib, you need to start them on warfarin or an anticoagulant regardless of CHA2DS2-VASc score. So you don't have to do CHA2DS2-VASc score for the patient with HOCM and Afib. Indication for ICD. There is a question about patient who already has a HOCM, and what's the indication for ICD? Indication for ICD, patient on risk. Septal thickness more than 3 centimeter. Family history of sudden death. The patient has history of VTAC or recurrent VTACs or syncopal attacks, or recurrent syncopes. So those patients need an indication for ICD. One of those examples, there is a patient, she's female, and her brother was just diagnosed with HOCM, and he fainted twice, and they ask you what to do next. Next is family screening for genetics and genetic counseling. If they ask you how to confirm the diagnosis or about the diagnosis, then you need to go for echo. Read about the differential diagnosis and how to differentiate between HOCM, athletic heart, and hypertensive heart. In HOCM, usually the LVH extend more than 3 millimeters. Those patients, all of them, you may see a young man or a young lady with S3 gallop, maybe S4 in elderly, maybe the patient asymptomatic, maybe there is murmur, no murmur. EKG, as we said, signs of LVH, echo, septum more than 15 millimeter. This is more goes with HOCM, usually focal or asymmetrical, not like LVH or athletic. LV dysfunction is common with HOCM, but not common with athletic and hypertensive heart. In echo, again, you will see asymmetrical LVH, SAM motion, systolic anterior movement of the mitral valve, systolic aortic outflow obstruction, which is outflow obstruction. That's what that term for OC, outflow obstruction. Hypertensive heart, LVH will be symmetrical, non-specific STT changes, maybe Q wave, and usually it's less than 15 millimeter thickness. Aortic stenosis looks like a hypertensive heart, but of course with the ejection systolic murmur, and will be clear on the echo. Those are differentials. It's good to look at them and to follow. Heart failure in a case of amyloidosis. The patient comes with a heart failure. There is also kidney problem, maybe ecchymosis under the eye. Thinking about amyloidosis is not a bad idea, and doing a skin biopsy. The suggestive signs and symptoms for amyloidosis: the patient has waxy skin, early bruisability, enlarged muscles, tongue, deltoid muscle, symptoms and signs of heart failure, cardiac conduction defect, abnormalities, low voltage, hepatomegaly, evidence of heavy proteinuria, signs of nephrotic syndrome, peripheral neuropathy, autonomic neuropathy, impaired coagulation profile. Then if you do an ultrasound to the kidney, you're going to see a large kidney, but the patient is CKD, which is expected to see atrophic kidney or small kidneys, signs of heart failure on echo, LVH, cardiomegaly, and if you're going to go one step further, you can also classify them to amyloidosis and what type of amyloid, AL or AA, primary or secondary, and the diagnosis. They use the rule for genetics and the total protein electrophoresis. There is at least 5 or 6 questions about syncope, dizziness, palpitation. It's always history is the key in diagnosis of those palpitation, dizziness, and syncope. Is it cardiac? Is it neurogenic? Is it non-cardiac? Is it inner ear, central, peripheral? What's the description that the patients tell, and what's the event? So those patients, initial study for those patients needs history, and if it's syncope or pre-syncope, you need to rule out arrhythmias. So you need an EKG, start with 12 lead EKG. Echocardiogram only indicated if the patients, or if you feel this patient has a structural heart disease. An echo, abnormal S sounds, murmurs, then you go for echo. If symptoms occurs on a daily basis, you need to understand the role of Tilly, Holter, or a chip to diagnose or catch some kind of arrhythmias if the patient complains of palpitation. So if the palpitation is less than 24 hours, 48 hours, and frequent, a Holter monitor is enough. But if it's more than that, you may need an event monitor for 30 days. If it's more than that, maybe you need to put a loop recorder, which is going to record for longer time. Syncope, if we suspected a structural heart disease, again, echo is the answer. If not, then you can do ambulatory monitoring with an EKG and maybe a blood pressure if you're thinking about POTS or orthostatic hypertension or autonomic. Tilt table test can be used for situational and other type of syncope, which would be the last thing to go for, maybe. Syncope, if it's diagnosed due to AV conduction defect, then the question will be about the role of pacemaker here. If you couldn't find anything in the EKG before you said this is normal or go for Holter or Tilly, just make sure the QT is normal, it's not lung. If he has a congenital lung QT, you can use a beta blocker if the patient is asymptomatic. ICD for patients are high risk, especially for VTAC, arrest, recurrent syncope, already on beta blockers, recurrent arrhythmias, already on beta blocker, or history of family sudden death. This is for congenital lung QT. They have a question about a patient with a COPD that's admitted with a COPD exacerbation, and they tried to treat him and they used antibiotic breathing treatment, but the patient continued to feel and look sick. And they have an EKG on the test, but they're not telling you anything more. Look to that EKG and look to the P wave. If it looks tachycardic and the P wave keep changing in morphology, this is MAT, multi-atrial tachyarrhythmia. You need to control his COPD, make sure his oxygenation saturation on the target level, and if he needs an antibiotic or to adjust antibiotic or add steroid. If not, and this doesn't help already given to the patient on the test, then the next step is to give the calcium channel blocker. And there is no need for DC shock or amiodarone on those patients. It's not an AFib. So they may try to track you, the patient's COPD exacerbation, the EKG looks like AFib. It's irregular because you're going to see different P waves, but but you still see the P wave, so it's not AFib. At the same time, they try to tell you, okay, give him a DC shock, give him amiodarone, give him dilatam or verapamil. The option is, of course, at this time is calcium channel blocker and rate control. They may have this patient who came with a heart failure, try improving, recovering. ACE inhibitor was added, spironolactone was added few days later on, but he came back with a shortness of breath, again dyspnea. EKG shows no P wave, but there is a wide QRS. So what do you think? Wide QRS, patient already on AC inhibitor and aldactone that was recently added. Check his potassium. So maybe this is start to the early signs of hyperkalemia, wide QRS, peak T wave, wide QRS. Then you may have a lost P wave and a systole. So those the ones you need to look, especially if you see the EKG with a wide QRS, but you don't see the P wave. There is no P wave. This patient is going to the last phase, which is pending arrest. So you have to start with CPK, calcium gluconate, bicarbonate, glucose, and K-oxalate, calcium, potassium chelating agents. All patients with a new onset AFib, you must check TSH. If the question gave you a patient with outpatient just coming to the ED with palpitation, you test him, you examine him, everything looks good, he's active, he's not in distress, and you decide to give him, and they already give him in the test beta blockers or rate control, and CHA2DS2-VASc score is okay, does not indicate for anticoagulant, and they said, okay, now start the patient on beta blocker, or they're gonna say discharge the patient with a beta blocker and anticoagulant, or discharge the patient and do treadmill or stress test or echo or send him for a cath lab. But one of the options was there is just test him for TSH. That's the right answer, TSH. All patients in new diagnosed with AFib must be tested for TSH. Patient has PVCs. If the patient has PVCs on EKG, if it's asymptomatic, you don't need to do anything with those PVCs. If those symptomatic PVCs, you start on beta blockers. Patients with persistent PVCs, despite beta blockers or calcium channel use, or other antiarrhythmic drugs used, and they still have the palpitation, the next step is to go for EPS and ablation. What's the other indication for ablation with patient with PVCs? Despite medical therapy, who can tolerate medical therapy also can go for a ablation, or patient who develop PVCs related left ventricular dysfunction or heart failure due to tachyarrhythmia. Orthostatic hypertension, one of the most common, actually not just on the test, also in reality. You have this elderly patient, she's on blood pressure, and doesn't matter if this blood pressure was added recently, the blood pressure medication, or he's been on this medication for a long time, and he came with altered mental status, or weak, or tired, or syncope, or pre-syncope. Always check his orthostatic blood pressure. If the blood pressure, systolic blood pressure dropped more than 20 or diastolic more than 10, this is diagnosis for orthostatic hypertension. It's increased in elderly and increased with patients' risk for fall. Knowing the most common cause for orthostatic hypertension, of course, dehydration, hypovolemia, the use of diuretics, GI bleed, make sure that this patient does not bleeding somewhere, hyperglycemia, blood sugar is high, that will put him at risk for polyuria and dehydration. Some medication side effects as vasodilators, either Viagra, alpha blockers, those medications can increase. Patient with autonomic dysfunctions, elderly patient, diabetic, again, they are on risk. Parkinson's disease, Lewy body, dementia, and peripheral neuropathy on risk for autonomic dysfunction. Obstructive sleep apnea, very common in the test. You may have patient with nocturnal symptoms, nocturnal palpitation, nocturnal desaturation, nocturnal arrhythmias, or early morning arrhythmia. They may mention he has or she has the loud snoring, may not. So your answer will be to do full night polysomnography. If the patient even has chest pain nocturnal only at night, then the test will be polysomnography. Most of the cardiac symptoms that happen during night or early morning, you have to suspect obstructive sleep apnea and do polysomnography. So obstructive sleep apnea, it has a very significant cardiovascular effect. It increases risk of coronary artery disease, increases risk of heart failure, pulmonary hypertension, and controlled hypertension. Symptoms of worsening symptoms at night because of desaturation at night, and increase the cardiac demand and demand ischemia. If the question about diagnosis or next step to diagnose, we need polysomnography. If the question about, of course, with EKG monitoring, and if it's a treatment, it will be the CPAP. Patients with arrhythmia, again with syncope, you may have a patient with on the test, but there is an EKG. If there is always an EKG, look to that EKG. Try to get the diagnosis even without reading the whole passage. Look to the all EKGs you can find on the MKS app, because usually they use the same EKGs there. Look for heart block, Mobitz type 2, complete heart block, Afib, A-flutter, WBW, and multi-atrial. Those are the ones are common on the test. Wrong placed leads, reversed one, you're gonna see a negative QRS in lead 1, which is usually should be positive in lead 1. A predominant upward PQRS T complexes in AVR, which should be negative with T wave negative in lead AVR. That tells you if this lead was misplaced and wrong placed. Bradyarrhythmia, symptomatic or asymptomatic, the use of atropine, the indication for transcutaneous pacemaker, if the patient hemodynamic is stable or unstable, WBW syndrome and WBW pattern means the pattern that the patient is asymptomatic, but there is an EKG finding suggestive of WBW syndrome. Then usually just rest stratification of those patients. You don't need to do any invasive test or exercise or a challenge test or APS for those patients. But WBW syndrome treatment for those with low risk is intermittent they have intermittent pre-excitation during fast heart rate treatment, or with or without treatment. So in general, the question will be, this patient with WBW, is he on high risk for sudden death or not? If there is a family history of sudden death, then the patient is a high risk for the syndrome. If the patient already had a pre-excitation with VTAC or VFib or tachyarrhythmias, then you need to do further workup. Afib, also common in the test. Patient with paroxysmal Afib needs rhythm control. The use of flecainide or propafenone are favorable because of their side effect. And paroxysmal, we talked about more than 2 episodes. Mitral stenosis, common cause for paroxysmal Afib, and patient with history of mitral stenosis who presented with palpitation or signs or symptoms of heart failure, shortness of breath, or choking sensation at night, then your next option is, if they ask you about the diagnosis, you need to do Holter monitor or event monitor to rule out paroxysmal Afib. So the scenario will come, patient known to have history of mitral stenosis, either treated or not treated, and now he comes with palpitation or choking sensation or breathing problem at night or occasionals. Then the next step is to do Holter monitor to diagnose him. Patient with the management of Afib, either pharmacological rhythm control or rate control. It's been studied. It's usually the rate control is the ideal, but if the patient after discussion with the patient and wants to go for rhythm control, he needs to understand that there is increased risk for the side effect, because those medications are going to be chronic, either amiodarone, flecainide, propafenone. So that's why we favor the rate control, which is less side effects, either beta blocker or calcium channel blocker. Anticoagulant again will be added as CHA2DS2-VASc score is high, or if patient has already HOCM, or if the patient has pericardial peripartum cardiomyopathy. Those patients, you add them regardless of CHA2DS2-VASc score. You may have some case scenario about a young patient with syncope and fainting after an event, a stress, situational, something happened, and everything looks otherwise fine, normal, he's awake, he's physical exam, no signs of structural heart disease, no murmurs, and the diagnosis will be vasovagal, and just reassure the patient. But an elderly patient with a syncope and maybe history of COPD, metastasis, cancer, advanced stage, they may give you tons of options what you're going to do for the patient, tele, Holter, this, that, but the answer in this case will be usually start the discussion of hospice, and you don't have to do any further workup. Maybe a young patient who was in the bathroom post-micturition and he felt syncope, kind of syncope, pre-syncope, dizzy. This is called situational syncope, either post-micturition, even post-tussive can happen. So usually the treatment to avoid the trigger. There is also the neural reflex during straining, squatting, can cause also syncope. Many mechanisms related are so vagal stimulation or reflex neurovagal. So treatment again, avoid those triggers as possible. Syncope due to severe aortic stenosis will be one of the questions there. If will be more an elderly patient, and they will give you that there is a murmur or ejection systolic murmur, or you already suspected a patient to have aortic stenosis there, then that's syncope related to aortic stenosis if it's exertional, happens during exertion. If it's syncope due to conduction defect like complete heart block or Morbid's type 2, it will happen without exertion. It can happen on rest. And that's brought us to a valvular heart disease. You need to know mitral valve problems, stenosis that always needs valvoplasty or ballooning valvoplasty. Most or all of those you need to be treated surgically, either open surgery or transaortic valve replacement, and even mitral clip. So it's a structural problems need to be fixed mechanically. They may ask about the role of anticoagulant, the target for INR, and the role of aspirin in addition to the anticoagulant, or dual antiplatelet in addition to the anticoagulant, which is it's not indicated anymore, triple therapy for any disease, but follow the guidelines and check for the up-to-dates. They may ask you about what to do with the anticoagulant before surgery. If the patient's low risk or high risk. If the patient low risk for bleeding or high risk for bleeding, depends on the surgery and depends on the patients. Then the decision about to stop the anticoagulant will be valid. The second question you need to ask, is he on risk of anticoagulant? High risk patient for clotting, DVT, PE, then you need to bridge them and keep the anticoagulant. And if they are low risk, then that's fine, you can stop it and resume it after the surgery. You may have some questions about murmurs, and they can ask you what's this murmur indicating. You may have aortic coarctation, and then you need to check radiofemoral delay. You may think about myxoma, and in myxoma patients, they may have this rumbling murmur. They may faint during fever, or may they have the B signs, which is systemic symptoms and signs of fever, and inflammatory marker is high. Maybe they have syncope, exertional syncope, and treatment is surgery. Infected devices also on the test. The patient has recently have a pacemaker, or even has a pacemaker or ICD, and he came with fever, tachycardia, blood culture positive, and the device is tender, or there is redness or collection. This device has to be removed. There is no nothing around that. You have to remove the device. There's a question about aortic dissection, severe chest pain, sudden tearing, ripping, and the patient continue to have the symptoms. What to do? Start with a blood pressure control, beta blockers before use nitroprusside. The patient may not, or the question not straightforward with just the chest pain, but the patient comes with tamponade or inferior wall MI. Then your next option for diagnosis is to do CTA, and if you see a false lumen, or you see a hematoma or a double wall, in addition, maybe you can see also on the test a high D dimer, then you're gonna of course treat and manage as an aortic dissection. Those patients on risk are patients with uncontrolled high blood pressure, Marfan syndrome, cocaine abusers, high risk patients like Marfanoid. You need to do physical exam. If a patient came without chest pain, without aortic dissection, and he has those Marfanoid features, and you do a physical exam for them, and you may find a murmur not clear, maybe there is a murmur, you need to do an echo, and you need to do a genetic testing for Marfanoid, which is fibrillin FBN1 gene mutation. Those with Marfanoid features also, that differential diagnosis will be Ehlers-Danlos syndrome, Klein-Filter. So those patients, you need to screen them for aortic ascending aneurysm and the possibility of dissection. You may have this patient with Marfanoid feature on the test, and they may have a CT scan with dissection, and it has a cut exactly at the ascending aorta, and you're gonna see there is the false lumen and the hematoma there. So make yourself familiar with those images. Defective endocarditis is very common on the test, and you need to look there and see what's the indication for antibiotic and what's the indication for prophylaxis antibiotic, and when to do surgery and surgical remove of that valve. Aortic stenosis in all valve disease, what's the indication for surgery and when to go for surgery. Mitral stenosis, aortic stenosis. AAA, abdominal aortic aneurysm screening and follow-up is also common on the test. You may have a patient with abdominal aortic aneurysm of 4 centimeter or less, then you need to do just surveillance screening with duplex ultrasound every 2 to 3 years. But if the size more than that, or 5.4 centimeter, then you need to do CTA or duplex every 6 to 12 months. So be familiar with those differences, when to go for surgery, when to operate on a AAA, and when the increase the risk for rupture. Peripheral arterial disease, you will have at least 2 or 3 questions, either about diagnosis of peripheral disease with a claudication, or patients already maximized with treatment, high dose statin, beta blockers, ACE inhibitor, aspirin, and patient continue to have symptoms. You need to know the indication for celestazole, And you need to know the indication for contraindication for silestazole, which is symptoms and signs of heart failure or low ejection fraction. They may ask you about the indication for percutaneous angioplasty. They may ask you about screening for peripheral artery disease. You always start with ankle brachial index API. If it's more than 1.3, this is including severe claudication. If it's less than 0.9, it's there is more than 1.3 means due to severe calcifications. But if it's less than 0.9, that means there is severe stenosis. The differential diagnosis always is lumbar stenosis or neurogenic stenosis. Usually it's bilateral, symmetrical pain, maybe associated with muscle weakness, abnormal nerve conduction test, abnormal sensory, and worsening with erect position or by walking, and decrease by rest or even just stop walking. Not like claudication that needs to sit and rest, but not just leaning forward, and they can do the pain in claudication in peripheral artery disease is not related for spine flexion or erect position like peripheral artery disease. Statin and statin-induced myopathy, one of the common diseases. You need to know the triggers for that. Patient already just had statin, or he's taking statin for a while or long time, and then he has alcohol, or he has started taking another calcium channel blocker added, or then you need to know that increase the risk for statin. But even if the patient's already taking statin, or you diagnose him with a statin-induced myopathy, you need to test them for TSH, CK, vitamin D, and those further tests depends on that case by case, if you need to do nerve conduction test or autoimmune workup. Other differential diagnosis for statin-induced myopathy is alcohol, connective tissue disease, electrolyte abnormalities, thyroid disease, neuropathy, peripheral arterial disease, fibromyalgia, vitamin D deficiency, and other polymyositis. Peripartum cardiomyopathy usually start month before delivery and may goes up to 5 months after delivery. The patient comes with symptoms of heart failure, palpitation, maybe Afib, ejection fraction lower than 35. You need to know the indication for anticoagulant, even as we said, regardless of the CHA2DS2-VASc score. Even if the ejection fraction below 35 without Afib, there is an indication for anticoagulant and usually warfarin. The management is the same as management of heart failure, but again, if it's in the during the pregnancy time, you need to avoid the ACE inhibitor, ARBs, and aldosterone antagonist, and can use, but those can be used as after delivery. Indication for ICD and CRTD are the same as heart failure. Is warfarin safe in pregnancy? Usually if the dose less than 5 milligram, that's fine, but it's more safe to use heparin or enoxaparin till the end of pregnancy. Which more safe, to go for CS or normal vaginal delivery? CS, there is more risk because of the anesthesia use and the risk for dehydration. So if it's possible to go for normal delivery will be much safer. Hypertension during pregnancy, they may have 1 or 2 questions about preeclampsia, proteinuria, neurological symptoms, hyperreflexia. Then you need to understand this patient is going for preeclampsia. You can use all blood pressure medications, but preferred are those, some medications are preferred and some medications are not preferred to be used, especially those with diuretics. Try not to use them, nitroprusside, nitroglycerin, because unless the patient really in crisis. But it's okay to use all beta blockers except atenolol. Nifedipine, the slow release, is okay. Methyl duba is a good option. Again, diuretics will be risky because of volume depletion and risk for IGR and small gestational fetus size and small pregnancy, placental insufficiency. Hydralazine, nifedipine, labetalol is good option. Nitroprusside, nitroglycerin during the crisis, that's fine, can be used. If a patient, there is a couple of questions with patient with hemodynamically unstable and indication for pressors. They're not going to ask you too much what type of pressor, but if the patient has a hemodynamically unstable, then next step will be for cardiogenic shock is to admit to the ICU and start on pressors. Venous ulcers, you may have an image of a medial side non-healing chronic ulcer with dark skin around that. Treatment is treatment with underlying disease, elastic stocks, compressives. The rule for statins and cholesterols in patient with peripheral arterial disease. Takotsubo, elderly patient after surgery, came with non-STEMI, cardiac cath, non-obstructive coronary artery disease. Symptoms and signs of heart failure. EKG shows this deep T wave, then treatment is symptomatic for heart failure. Patients was recently prescribed ACE or neprilysin and start to come back with cough. Then this is medication induced due to bradykinin. Blood pressure medications that increase risk for gout, like diuretics, less likely beta blockers, ACE inhibitor and ARBs has no uricose-uric effect. So if the patient, there is actually one of the questions that patient already has high blood pressure and they ask you what blood pressure medication you're gonna use. There is the diuretics there, the thiazide is there, maybe beta blocker one of the options, ACE inhibitor is one of the options. So if you're gonna choose between those, it's better to use ACE inhibitor or ARBs because they don't have a uricose-uric effect. And also, of course, they have an effect on RAS system and prevention of the kidney disease, so it's also another indication to use ACE or ARBs. But the next option will be calcium channel blocker, and if you're gonna use diuretics for any reason, try to avoid hydrochlorothiazides. You may have one or two questions about preoperative evaluation before surgery. If you need to do any workup, if the patient high risk for heart failure or coronary artery disease, yes, you do the workup. But if he's no risk, you don't need to do workup. Patients with high risk are patients with symptoms or signs of heart failure, or patients with unstable angina or symptoms of unstable angina, then yes, you need to do workup before the surgery and optimize the treatment before the surgery. People with low risk, mean cardiac risk score RCRI less than 1%, and they are stable and asymptomatic, or MET score more than 4, they can go upstairs, they can run, they can walk. Even if they have baseline coronary artery disease or heart failure, you don't need to work them up before surgery. You don't need to do an echo, you don't need to do stress tests, you don't need to stratify them before the test. They will have a question about when to start screening for lipids, because this has just been changed in the guidelines. Age 20 years and more, they need to start and screening them for hyperlipidemia. AAA and smokers, age 65 to 75. Osteoporosis, female, age above 65. Lung cancer, you start with CT, low resolution for patients with smokers from age 50 to 80 if they smoked more than 20 years, or even if they stopped and quit but it's been less than 15 years, then you do screening. You don't have to do screening for lung cancer if the patient stopped more than 15 years or they have short life expectancy, associated other comorbidities, and there is no point of working them up. And even if you find the cancer, they will not be a candidate for surgery or chemoradiotherapy. HIV, we mentioned that in the infectious disease at least one time in life for everybody from 15 to 65 years old, and for those on risk it will be annually. Congenital heart disease, you will have a question about VSD, ASD, Turner syndrome, association with coarc, bicuspid aortic valve, and association with AI, aortic insufficiency and stenosis, superior vena cava syndrome with a dilated neck vein, and increased risk of hypercoagulability, or they have a dialysis catheter. You need to diagnose them, and their differential diagnosis from Steele syndrome, vertebral, with either vertebral stenosis, or if they have syncope, vertigo with upper limb exertion, or if there is, in physical exam, there is decreased pulses and volume in the upper extremities, and usually Steele syndrome more common on the left side. Pancreas tumor, if there is a mass or lymph node and significant weight loss. Pericardial effusion can give you also dilated veins, but usually will be bilateral, and facial swelling and pulsus paradoxicus. Statin, you may have this question. Yes, statin can increase risk of glucose intolerance, but the benefits are overweight the risk here, and you don't stop statin even if it's the patient blood glucose is not controlled. Statin with hypothyroidism increase risk for rhabdomyolysis and statin-induced myopathy. Statin with calcium channel blocker increase the risk of rhabdomyolysis and statin-induced myopathy, and increase the risk of elevated liver enzymes, but they're not going to reach to a risk of liver failure or cirrhosis, so you still keep them if less than 10 folds. Secondary prevention for the use of statins, always high dose statin. You're not going to give them just Lipitor or atorvastatin 20 or 40, it has to be high dose 80. No clear benefits for adding statin for patients with end-stage renal failure, established end-stage renal failure. We don't have to start primary prevention with statins. If LDL less than 190, you can start as primary prevention with moderate intensity statin therapy for patients from 40 to 75. Moderate intensity therapy also from 40 to 75 with patients in risk of cardiovascular event more than 7.5%. High intensity statin for patients with cardiovascular risk more than 20 or higher. So those difference between moderate and high intensity statins depends on the cardiovascular risk score, if it's above 10 or above 20. There is a photo about patient with chronic venous insufficiency, an elderly patient with evaluated for painful ulcer in either likely in the medial side of his leg. It looks dark with brownish discoloration in the whole leg. Peripheral arterial and pulses are intact. Ankle brachial index is normal or looks good. Sensation intact. Toes warm. There is hair, there is pulse, capillary refill looks normal. They're gonna ask you, what's this? Very likely this is venous ulcer due to venous insufficiency. A post-MI pericarditis and the use of high-dose aspirin. Avoid NSAIDs if it's post-MI. The use of steroid, the use of anticoagulant. Pericarditis versus perimyocarditis, when you see an EKG changes, or you see a T-wave inversion, or you see also troponin is positive. Pericarditis or perimyocarditis, which is either viral or non-specific etiology but not post-infarction, the rule or the treatment will be NSAID with colchicine, and try to avoid steroid as a standard therapy, because this is going to be increase the failure and recurrence of the disease. Pericardial disease always increase risk for tamponade, so on physical exam look for pulsus paradoxicus, which is rapid X descents in the jugular vein, and decrease in the blood pressure and increase in the heart rate. Angioedema with the use of AC inhibitor, you need to know that it's safe to use ARBs. but you can't use Entresto or Arni with ARBs because both increase risk of angioedema. Femoral puncture after a cardiac cath, and patient comes with a hematoma. He has a tender groin, blood pressure dropped. You need to do abdomen and pelvis CTA to rule out retroperitoneal hematoma, and treatment will start with manual compression or under ultrasound guided, and cross over clamp will be the final answer. Pre-operative stopping Plavix at least 5 days, a patient high risk. You can keep or continue aspirin, that's fine during now most of the surgeries. Lifestyle changes always helpful, and it's always good to advise all your patients with lifestyle to decrease their cardiac risk. Means exercise more than 150 minutes per week. Mediterranean diet, where that means less red meat, less salt, saturated fat, and less sugar. So DASH diet, smoking cessation, and moderate alcohol intake. Those are the lifestyle changes that decrease the cardiac risk. If a patient came with a history, they may have this middle-aged elderly patient, diabetic, and always after eating he feels syncope or feels dizzy, and blood pressure dropped. If the blood pressure dropped more than 20 millimeter mercury within 2 hours post-meal, then this is postprandial hypertension. Usually this kind of hypertension worsening with anti-hypertension medications, and it's common in elderly patients. You advise your patient to take small frequent meals, low carbs, increase sodium in their diet, avoid alcohol, maybe use a compressive stocks, avoid sudden standing from sitting position, and if it's severe and refractory or in the test already used those things and all conservative measures, patient continue to have hypertension postprandial, you can use octreotide. And that's conclude cardiology, and good luck in the test.